Good day and welcome to this webinar on quality of life in patients with osteoporosis, impact of sexuality and touch. I'm Dominique Pierrot, Science Manager at IOF, and I'm the moderator of this webinar. Before introducing the speakers of the day, I would like to inform you that attendees are automatically muted. I also would like to encourage you to ask questions during the webinar by typing them into the question box of the control panel, and I will voice them to the speakers toward the end of this webinar. So now I have the great pleasure to welcome Dr. Miriam Hashem and Ms. Agnes Hoffenberg. Dr. Hashem is a sex therapist with a PhD in linguistics from the University of Utrecht in the Netherlands. She is a member of the Dutch Scientific Association of Sexologists and the Dutch Foundation of Sexual Wellbeing. Ms. Agnes Hoffenberg is a nurse practitioner working in the endocrinology clinic at Zans Medical Center in the Netherlands. She has a master in advanced nursing practice, and she is a board member of the Dutch Scientific Association of Sexologists and the founder and chairwoman of the Network of Endocrinology Nurse Practitioners. Dr. Hashem, Ms. Hoffenberg, thanks again for having agreed to speak today. We are delighted to have you with us, and we are listening to your presentation.
Thank you. Thank you for welcoming us and for being here. Thank you very much. And welcome everyone who is watching. We are so happy that you're here. And we are really excited to get started on osteoporosis and sexuality today. So first, I will start by giving you an overview of the presentation that we will give. The presentation has 4 parts. The first part is what patients are dealing with. So we will give you an insight into the problems that patients experience in their real lives. The second one is the impact of osteoporosis on the patient's sex life and love relationship. So we will, in that part, we will focus on how osteoporosis disrupts the roles of the partners in relationships and the stress that results from that, and what patients need to be helped with that. In the third part, we will show you what happens when patients don't receive the help that they need and they stay in their situation alone and not knowing what to do. And that has certain consequences for healthcare that we will show you. And in the last part, we will answer the questions how we can help our patients. And we will also provide you with tools that you can use in your own practice if you want to get the conversation on sexuality started. We will do the first part together, then I will do the second part, and Agnes will do part 3 and 4. Right. So let's get started with the first part. So when you're a human being, you are also always a sexual being. So sex is simply at the basis of our nature. And so it doesn't matter whether you are healthy or whether you have a chronic disease, you are always also a sexual being, and that never goes away. So sexuality is really a fundamental part of our humanity. So sexuality always needs to be integrated into our lives. If it doesn't, if it falls away, then that can be experienced as a terrible loss. And for most people, regardless of whether they are healthy or whether they are sick, when they lose their sex lives or they lose their connection with their sexuality or their body, that loss can feel almost unbearable. So what happens when someone develops a chronic disease is that it disrupts the experience as a sexual being and the way we have lived our sexuality so far. So you can imagine that when you have osteoporosis, your bones become weaker. And so maybe before you develop the the disease, you could do, any sexual position or any sexual movement, or, hugging your partner really tight, or whatever you would like to do. But then in the course of the disease, all of a sudden, hugging someone really tight breaks a rib, or thrusting during sex can injure your hip, for example. So the way you have sex and the way you experience sex is being disrupted. The second thing that happens is that chronic diseases remove us from what society regards as sexual. And society thinks about sex only as this, like these two beautiful young people, very erotic and sensual. But the reality that patients might be living with is what we see on the picture on the right. And then this can create the feeling that you are sexually discarded. It's like you're not a sexual being anymore because society has a very restricted view of sexuality. And that impacts your patient's feeling of self-worth. So the consequences of osteoporosis can be bones become weaker. There can be a dissonance between your body image and the way your body changes. And your body changes in ways that make you feel sexually unattractive, like rounding of the back. And sexual movements become painful and dangerous. Or some sexual positions become impossible, maybe your favorite. You can't fulfill your own and your partner's sexual desires anymore in the way that you used to. For osteoporosis patients, it can feel like they are losing their sexuality. And this creates a great emotional hardship in their lives. It's important to realize that loss of sexuality does not mean that you actually lose your sexuality. That's impossible. It's about the feeling that you lose your sexuality. This includes not feeling like a sexual being anymore, or not feeling sexually attractive anymore, feeling sexually incapable, or feeling sexually disregarded by your partner and society, becoming sexually inactive. And so what are patients telling us? Patients can be experiencing pain, lack of energy, lack of interest, decreasing feeling of self-worth, and fear of fractures or actual fractures. And they will want to know how to avoid pain, risk, and fear. They have said that healthcare professionals do not initiate a discussion about the topic. And also research has shown that the majority of healthcare professionals do not proactively discuss sexuality issues with their service users. And Jose Al, a therapist and also a chronic patient, has given us, it has improved for us to use her quote on this. You're at the sidelines of life, not being of essential value. And when your self-worth and self-image collapse like a house of cards, little remains of the feeling of being attractive and desirable. And what are patients telling us? The burden of disease, the hardship that patients suffer due to the disruption of the sexual experience aggravates the burden of the disease. And this includes decrease of self-worth. They go from partner lover to patient. And relational stress, loss of intimacy, touch, connection, love, loneliness, and the consequences thereof. Intensified experience of pain. The osteoporosis depression cycle. More physical and mental emotional health problems. Patients need even more help here. In this journal, a lot of very important theories are described. And it's important to know that healthcare systems that state a commitment to improving patients' overall health must have resources in place to address sexual concerns. These resources should be available for all patients across the lifespan. All right, so now we move to the second part, which is the impact of osteoporosis on the patient's sex life and love relationship. Oh, so this has three subsections. Sorry. The first subsection is the psychological and physical stress that arises from painful sex. So this is also what I mentioned earlier, that that osteoporosis can lead to injury and fractures during sex. We will look at the consequences of what painful sex does to people. Then there's the relational stress that arises from trying to have a sex life when partners become caretaker and patient. And the psychological and physical stress that arises from a lack of touch. So let's start with the first section, the psychological and physical stress that arises from pain. Now, sex can be immensely beautiful, deeply fulfilling, an all-encompassing sensual experience for humans. But this is only possible when the sex is wanted and pleasurable. So this is really the two crucial ingredients of fulfilling sex, is that the sex is wanted and that it feels. When the sex is either unwanted or unpleasurable, it has the opposite effect. It means it becomes traumatizing. And this is also true when the sex happens in the love relationship and out of love for your partner. So usually when we talk about sexual trauma, we immediately think about abuse and rape, very like violent kind of sex. But when you have sex, for example, let's say, for example, you have a situation where one partner wants to have sex and the other partner doesn't. And then the other partner says, oh, well, I don't want to have sex, but I will do it for my partner out of love or out of duty, because I want to be a good partner and I want to make my partner happy. Then that's very nice, but it's not good for the body, and it's not good for your sexuality. What happens is that when you do this over many years, the body develops gradual, small sexual trauma over time that keeps building up until at some stage, and it can take 5 years, 10 years, 15 years, depending on the person, the body will completely shut down. And also, sexual desire goes away, and at some stage the body shuts down. And this is why it's really, really important to protect any relationship, or that also partners protect each other from unwanted and unpleasurable sex, because it has a very strong impact on the partner who goes along with it. Now, when you have osteoporosis, the sex can actually become dangerous, like we said before. It can be painful, and it can cause fractures and injury to the body. So the problem that osteoporosis patients are dealing with is that you might want to have sex with your partner, but it's too dangerous, too painful, or it causes actual injury, for example, from the forceful movements or holding each other. So you get a situation where you might want to have sex, but you can't. So what is the need of the patient in this situation? So first of all, the patient needs guidance in making sexual positions safe and pain-free. Then they need guidance in developing other ways of intimacy and sexual pleasure than conventional penis and vagina. So there's a very strong bias in our culture, but also in the medical model of sex, that when you have when the penis goes into the vagina, the sex is working. But there are so many other forms of sex, manual sex, using your hands, oral sex, using mouth, and just general physical sensuality with each other that includes the whole body, all of the skin, and not just the sex organs. That is just as important, or actually even more important than only penis. And it's really important to open people for that idea. It's important to help patients not to see this as a loss, but as an opportunity for a richer sex life. So it's not, so developing new ways of intimacy means that you increase sexual activity and that you are broadening your sexual repertoire. And it not only means that you're losing what you used to do, but you're learning new things. Now I will talk about the relational stress that arises from trying to have a sex life when partners become caretaker and patient. So chronic diseases have a fundamental impact on love relationships because they change the roles that partners have in the relationship. So partners in love relationships fulfill several roles with respect to each other. They can be lovers, they can be companions, they can be confidants, they can be advisors, and some partners are even business partners with each other. What's important to understand about relationships, about love relationships, is that they flourish when partners are in roles of equality. So companions is a role of equality, lovers is a role of equality, advisors, confidants, those are all roles of equality. But when partners enter roles of dependency, that relationship then brings a lot of strain and stress into the relationship, and it can also create the feeling of suffocation. This is, for example, when one partner starts to act as the parent of the other partner, or the problem solver of the other partner, or the therapist of the other partner. Also, when you have very extreme economic dependency, that can also create feelings of suffocation and powerlessness. So it's important also that in relationships in general, always to think about, okay, what are the roles that the partners are playing towards each other? Now, when a chronic disease enters a relationship, because one partner develops a chronic disease or both partners develop diseases, then the roles in the relationship changes. So first, well, in an ideal situation, the partner were in equal roles. It can already be that they weren't. But for this example, let's say that before the roles were more or less equal. And then the roles of patient and caretaker are introduced. Because the moment one partner develops a chronic disease, the other partner will want to take care of their partner. And there's nothing wrong with that. So it's beautiful and wonderful. But it's still a very strong role of dependency. And so the moment partners become patient and caretaker, there will be stress and strain on the relationship. It's unavoidable. And it's important to be aware that this is simply something that results from those roles, and that we need to help people to deal with the stress and strain that they will definitely experience. So even if these roles, so even if the caretaker does the caretaking with all their love and all their dedication, there will still be strain and stress. And this happens in two ways. So in order to take care of someone, you have to set your own needs aside, even if it's temporary. But you have to do it. And still, as the caretaker, you have your needs, and you need your needs to be fulfilled as well. So even if you put your needs aside out of love and being sad for your partner, it still means that you will, in the course of time, get a buildup of unfulfilled, and that creates stress. At the same time, the dependent partner, the patient partner, can experience tremendous guilt towards the caretaking partner because they feel like they're becoming an obstacle in their lives, and now the caretaker cannot do everything they wanted to do, and it's their fault, and so on. So it becomes emotionally very complex. And another way in which a relational stress is created is through the disruption of the lover's relationship. And this is the part that I want to focus on today, because that's where the sexuality comes in. So I want to give you an example of a monogamous couple, because, well, I mean, there are many relation forms today, but most couples still are monogamous. Now, monogamy can be a relationship of equality or dependency, depending on how it's practiced. And this is really fundamental to understand about monogamy. And this is the reason why some monogamous couples are very happy and other monogamous couples are very unhappy. So being aware of the fact that monogamy can be either equal or dependent is very beneficial when you want to give advice and guidance to patients with osteoporosis. So the first kind of monogamy that I want to talk about is equal monogamy. So equal monogamy is when both partners have approximately the same amount of sexual desire, and when they also have the same enjoyment of the sex that they are having together. When that is the case, the partners feel connected, they feel free, they feel fulfilled, and the sex life goes really well. But you can also have a dependent monogamy. And this is when one partner has or develops more sexual desire and more enjoyment in the sex than the other. And what then happens is that the partner with more sexual desire becomes dependent on the partner with less sexual desire. Given that you're monogamous and you say, all right, we are exclusive, we are the sexual partners of each other. Once you get an imbalance in desire or in enjoyment, so for example, when you have one partner who simply doesn't enjoy the sex while the other one does, then the partner who doesn't enjoy the sex will want less sex, or at some stage will not want any sex. And then the partner who wants to have sex and who enjoys sex will become dependent on that partner who actually wants to who doesn't want to do it anymore. And the consequence is then that you get an emotional relationship where one partner keeps initiating and the other partner keeps rejecting. One partner keeps asking for sex and the other partner keeps avoiding. And at some stage, the partner with more desire feels frustrated and rejected and lonely and hopeless. And the partner with less desire feels suffocated, pressured, guilty, and so you get a lot of very uncomfortable emotions going. Now, when you have chronic disease and monogamy, and I just want to to really emphasize this. When you have chronic disease and monogamy, the caretaking partner becomes sexually dependent on the patient partner. And this is so important to understand, because usually we only think about dependency the other way, right? So that what I said before, that the patient partner becomes dependent on the caretaker. But when it comes to the sexual relationship, the caretaker actually becomes dependent on the patient. But the patient is the one who is much less sexually capable. So even if they want to, they still run into the problems that they might be in pain, which we want to avoid, or that they might suffer injury, which is also what we want. And that creates an even more complex interplay of guilt, because the patient partner might feel guilty towards the caretaking partner. They also they are struggling with all the things that we mentioned, the changing body, loss of self-worth, not feeling sexually attractive, not feeling desirable, feeling like they're losing their sexuality. And then there's the caretaking partner who then becomes sexually dependent on them and who wants something that they feel like they can't provide at all. At the same time, the caretaking partner can also feel very guilty, because they think, my partner is already sick, and they are already suffering so much, and now I even want sex from them, which is really hard for them to give me. But I also don't know what to do with myself then, and I have needs too, and I'm a healthy sexual person, so this creates a lot of inner conflict in both partners. So the question is, what do we do now? So the partners think, what shall we do? Do we live with it? And one partner will walk around with the unfulfilled needs all the time. Shall we do an open relationship, which brings a whole other potential for emotional complexity and pain and jealousy, and for the patient partner, the feeling of being discarded, so I'm here and I'm sick, and my partner is somewhere else having sex with another person. Or does the caretaking partner try a secret affair? And this is something that happens a lot when one partner becomes very sick, that the caretaker starts a secret affair somewhere. And then when that comes out, there's a whole lot of emotional pain, and maybe it affects the social circle. So all of that is very complex and very problematic. So the alternative would be that we help partners to find new ways of sex and intimacy within the bounds of the disease. And generally, this is what the way I see it from what I see in my own therapy practice, this is usually what people want, because people have been together for a long time. They know each other deeply. They love each other. They want to be together, and they want to find a way to make it happen. So when people actually look for sex outside the relationship, then you're already very far escalated somewhere. And we really want to help people not to escalate to that point, unless, of course, it's really their free choice and it's really what they want. And we will, so in the last part of this presentation, Agnes will show you some really great tools on how to have that conversation with the patient. So for now, so in this part where I'm speaking, we're focused on the problems. So now you have really gotten a picture of the stress and the strain in the relationship, and now I will move on to the section about touch. So this section is about the psychological and physical strain that arises from a lack of touch. So let's say we get an escalation in the relationship, and the partners do physically withdraw from each other. So they stop having sex. Maybe the caretaking partner looks for someone else, and they simply don't get into physical contact anymore. So so one thing I wanted to say first is that our skin is our most important social organ, and we need to be in physical touch with other human beings to feel connected and to be healthy in all ways, physically, mentally, and emotionally. And there's a large body of research, and that research has been going on for 50 years, that shows that touch plays a fundamental role in all aspects of our lives. That is infant development, cognitive and social development, mental health, self-perception, social behavior, and so on. And in the references that you will receive afterwards, you will find an overview article that reviews that research. And if you want to go into that research more, you will find all the relevant references in the review article. So today, I just want to give you a little insight into the magnitude of the problem that is loss of touch. And I want to emphasize only one little part of that, and just that one little part will show you how big the problem is when humans don't have physical touch with other humans. So on this picture, you see the skin. And the different layers of the skin. And then you see a red circle, two red circles. And the one red circle, you see the letter CT, and it goes to, it depicts a nerve ending that is under the skin connected to the hair. Now, CT fibers, so those are the nerve fibers that are under the skin. So there are many nerve fibers under the skin, but those are the ones we will talk about today because they have a huge impact on our emotional well-being and our general health. Now, CT fiber stands for C-tactile efferent fiber. Efferent meaning that the nerve sends impulses from the body to the brain. And these impulses are then interpreted by the brain. What's special about CT fibers is that they only react to affectionate touch. So it's really like really slow, intimate, loving touch. And any other touch, they don't register. So if you do this, it will not be registered by your CT fiber. So if you hit yourself on your arm. And the other important thing is that CT fibers are connected to the insular cortex of the brain. And the insular cortex is involved in many different functions. So, among others, self-perception and self-awareness, interoception, that is the perception of the inner bodily sensations that we have, emotional regulation, emotional guidance of social behavior, and much more. And in the references, again, you will find research that you can read if you're interested. Now, what's important about, sorry, 1 second. So what happens in the relationship between CT fibers and the insular cortex is that CT fibers can send signals to the insular cortex without any further evaluation of the nervous system. So any other touch would still be evaluated. Is it painful? Is it not? Is it, did I bump into something or did someone hit me? But loving touch, the signals of loving touch are immediately sent to the brain, and they are there to the insular cortex, and they are there immediately interpreted as feelings of belonging, feelings of love, feelings of self-worth, feelings of being connected to other human beings, and so on and so on. So when we have loving, affectionate touch, the signals that are sent by the CT fibers to the insular cortex, they have a positive impact on our self-image, and a positive impact on our feeling of belonging with other human beings, and a positive impact on the feeling of being connected. And those feelings are very important for our general emotional health. So here are some consequences of CT stimulation through affectionate touch. So when it's a little bit what I said before. So when we have affectionate touch, we feel all these great feelings. We also feel calmer, and an indirect consequence is pain reduction. Now, this does not come from the CT fiber itself, but from the fact that feelings of belonging and love and positive self-image, they have as a consequence, again, that there's more oxytocin is being produced, for example, and oxytocin is a natural pain killer, or that endorphins are produced, or that dopamine is produced. And all these hormones that are produced as a consequence, they give further positive stimulation to the body, and they keep the body calm. They make sure that we have less anxiety. And I find the pain-killing effect most important when you think about chronic disease. Now, when we don't have affectionate touch with other human beings, we get the opposite effect. So we experience feelings of exclusion and loneliness, feelings of not being loved, decreasing and negative self-image, decreasing self-worth, and anxiety. And again, as an indirect consequence, you get an increase in pain due to the anxiety pain cycle. So there's really great research from chronic pain patients that shows that when humans get into anxiety, pain increases, even if nothing else happens in the body. So for example, even if you have a sports injury, You know, you have a good day, you hardly feel it, and then the next day something happens that makes you really anxious. All of a sudden, your knee might start hurting like hell, and there's no physical cause to that. It is simply the fact that you felt anxious that increased the pain in the body. And so we can use touch and intimate touch and physical contact between partners not only to create emotional well-being, but also to reduce physical pain. And it's something I really love personally. Yeah. So that was my part. Thank you for listening. And now we are moving to the consequences.
Yes, we will talk about the consequences. Compliance can decrease. Current situation in treatment with osteoporosis medication, it often takes years. Or after 1 year, about 50% of the patients have stopped taking medication. The majority have stopped medication after 3 months. Adherence is increased by the quality of the interaction, including the patient-provider relationship and patient satisfaction. Relationship with the healthcare provider is an important factor in patient compliance and success of the treatment. And the way people feel impacts the relationship with the healthcare provider. So a positive relationship with the patient is very important. When patients have the idea that they cannot talk about their healthcare provider, cannot talk to their healthcare provider about their private problems, they feel disconnected and alone. Patient-centered communication is associated with positive therapeutic alliance by responding to the needs of the patient. So healthcare consumption increases. That can be by increase in healthcare needs because the burden of the disease aggravates the problems of the patients multiply. Healthcare professionals regardless acknowledge the importance of sexuality for their patients, but have difficulty acting on their beliefs. So what can we do to help our patients? It can be very difficult for a healthcare professional to talk about sex with their patients. Sexuality is a taboo topic. And depending on your own relationship with sexuality, it can be an uncomfortable topic for you. Sexuality is highly personal and private. You can be afraid of violating the patient's privacy and also being afraid of judgment by colleagues. And when patients have the idea that they cannot talk to their healthcare provider, and lack of confidence, by being afraid that you don't have the experience to talk properly about sex with your patients and have the idea that talking about sex should be handled by a qualified specialist. Or you can be afraid of acting outside your own discipline. Our culture has a strong bias that only young and able-bodied people are sexual, while older people and people with disability and people with diseases are regarded non-sexual. Given that we're all part of that culture, we find the same biases in the medical community. And sexuality for people with chronic diseases and disabilities is often regarded as irrelevant or a luxury. The medical model.
I'm sorry, Ms. Offenberg. Can you speak a bit closer to the loudspeaker?
Yeah.
Because it's a bit more difficult to understand you. So like that it's better. Okay. Sorry for the interruption, but that's nicer. That's better for the audience. Thank you.
So the medical model of sex is restricted to the mechanics of the sexual functionality, and this means when the penis goes into the vagina, the sex is working. But within that model, sexual problems only arise when those mechanics don't work. So when the penis cannot go into the vagina for whatever reason. The greater aspects of sexuality, such as intimacy, closeness, connection, and sexual pleasures are not recognized by the medical model and therefore largely ignored. This is a problem because those aspects have the greatest impact on a person's quality of life. And whether the penis goes into the vagina or not says nothing about the quality of someone or a couple's sex life. When a patient opens up to healthcare professional about when a patient opens up to healthcare professionals about their sexual challenges, it can feel uncomfortable and overwhelming. Yet the need of the patient is very clear. Patients want to have this conversation, or at least options to talk about it. So what we need to do is change our mindset. Because sex is such a personal, private, and taboo topic, talking about sex is a fundamental expression of trust. Think about this trust as a gift. It means that you have done something or acted in some way that gave them the trust, the confidence, and open up to you. Take this as a compliment. And what to do with this gift? Step one can be awareness of the patient's situation. The patient makes themselves extremely vulnerable by opening up to you. And never underestimate the shame, unworthiness, and insecurity the patients feel about their sexuality. Be aware of testing. The patient will test the waters before they open up. They will probably belittle the problem. Step two can be to offer no solution, just listening. What you can do is in the moment of opening up, people are not looking for solutions. They want to feel seen and heard. They feel terribly embarrassed and ashamed, and they will want to know if they are normal and not crazy. What you don't do is apologize and reject and say, this is not my area of expertise, but I can refer you to a specialist. Step three is empathy and confirmation. You can say things like, don't worry, no need to feel embarrassed, this is totally normal. Or this is totally normal, so many people struggling with it. And we are more than happy to help you. Tell more about your situation. Step four can be connecting with a specialist. What you can do is say, if you would like help with that, I'm more than happy to connect you with the right people. We know people who are specialized in exactly these problems, and they are more than happy to help you. You don't say this, I can refer you to a specialist, sexologist, or therapist.
I just want to say something spontaneously that comes up. So the reason why for the patient, there's a really big difference between the do and the don't on the slide. So when a patient hears, I'm happy to connect you with the right people, all of that is about connection and empathy and opening up. But when you say, I can refer you to a sexologist or I can refer you to a therapist, it's like you're brushing them off. And the patient will experience that as rejection of maybe who they are and their entire sexual problem. And well, what we know from sexology is that these these differences in the way we talk to people, they can make a difference in whether they trust another healthcare provider or not. So yeah, that's why I wanted to stress this point. So when you say I can refer you to something, like send someone away, it can have the effect that they will never talk to someone else for 5 years. So yeah, just wanted to bring it in there. Thank you.
Useful tools for the healthcare professional can be, for example, the BETTER model. It's originally from the oncology. And you can bring up the topic, explain you are concerned with the quality of life issues, including sexuality. Tell patients you will find appropriate resources to address their concerns. Timing may not seem appropriate now, but they can ask for information or help at any time. Educate patients about the side effects of a report or assessment and intervention in the patient chart. Another model for our conversation is the implicit model. First, you ask permission, and you give permission to ask a question, and then you give limited information or specific suggestions, and if needed, you refer to an intensive therapy. There's also an extended visit model. And the important point of this model is that it's more focused on permission. So healthcare professionals tend to skip this step and move immediately to sharing information. There's also another useful tool for healthcare professionals, and that's a discussion and guideline, a guidance document for the nursing work. And this resource uses the extended visit model. It uses, I can't see the total screen.
Yeah, so just so what's happening is that the extended visit model was developed because healthcare professionals tend to skip the step of permission. So the patient really needs to get hear very clearly that they are permitted, they are given the space to talk about their sexual problems. There needs to be an explicit permission to the patient to do that. Like, for example, that could be what we know. So imagine you're in a conversation with a patient. You could say, we know many people who are struggling with this disease, and we hear from them that they suffer in their sex life or that they are unhappy in their sex life. If that ever happens to you, or if that's already happening, feel free, tell us about it. That would be an explicit permission from the patient. And the reason why the extended implicit model was developed after the first implicit model is because healthcare providers tend to skip the moment of permission because they think, and that's also understandable, well, my job is to give the patient really good information. So they skip the permission, which is the first step here, you can see on the screen, and they go immediately to information. But it's really important not to skip the permission step, and that's what the extended visit model is about. And in this document here, all the people in care homes, sex, sexuality, and intimate relationships, that's from the Royal Nursing College in London. And they have examples of how they use the extended visit model to talk to elderly people about sex. And you can use that in the exact same way to patients with osteoporosis or any other problem.
And there's also advice you can give to patients with questions about having pain in the back during intervals. And they can have certain positions where the pain will be less, or probably, or even better, no pain at all. And of course, on the internet, you can also find pictures to help you explain. And this was our presentation. And as a last remark, I would like to make a special point about the partner of the patient, because we always focus on the patient, and the partner has obviously the same issues, problems like these. So thank you very much for listening.
Thank you.
We are very curious about your questions.
Thank you for listening.
Yes. Thank you very much, Ms. Offenberg and Dr. Hashim, for this very interesting presentation on a very sensitive topic, I would say. So now I would like to move on to questions, as we have received some during your presentation. And maybe I will just start with the first one. So we know that osteoporosis has an impact on sexuality, as you just mentioned and explained, but does sexuality also has an impact on osteoporosis?
Yes,
Maybe may I ask you to come really in front of your microphone to answer the question, please?
Yeah. Yeah, so definitely, so it would have the indirect effects that we talked about before. So when you find a way for partners to stay sexual within the bounds of the disease or what's possible within the disease, you get all the positive health effects of a healthy sex life. And also, you can offset some of the negative consequences of osteoporosis. So we talked about the change, the drop in self-worth, the difficulty of dealing with a changing body, for example, your background, and that general feeling of becoming undesirable, of being discarded by society, and so on. In the references, there's a study that was briefly mentioned from the Journal of Sexual Medicine. We briefly mentioned it in the presentation. That shows that a healthy sex life is even more important for people with diseases than for people without diseases, because it has such an impact on the overall quality of life. And from that, you get indirect effects on the osteoporosis, because the patient will feel more connected, will feel a decrease in pain due to the mechanism we discussed before. So, but I do have to say, for everyone who really loves science, it's not like there's a direct scientific study that shows positive effects of a happy sex life on osteoporosis. But I think that from the research that is there, we can infer that there is such a positive effect.
And also, when stress increases, that has an effect on osteoporosis. So it will have endocrine consequences that can influence the osteoporosis.
Thank you. Another question. So you gave a very nice tip on how to refer a patient to a specialist, but the question is, how do I know when to refer the patient to the specialist?
Well, basically, yeah, as soon as you feel incompetent. So as soon as you feel like this is really totally out of my expertise. And that was also one of the 4 reasons why healthcare professionals avoid the topic, because they're afraid that they're outside the discipline. But the only thing that you need to do, regardless of what your specialism is to make the patient seen and heard. You don't have to give any specialist advice or anything that they can do, unless you can, for example, use the tools. Like, one thing that would be great for all of us is to have like a toolkit that you can give to patients, but so far that hasn't been developed yet. But when you feel like, okay, this goes further than what I can do, and it probably will, then you can immediately say, I'm so happy to help you and to connect you with the right people. So this is a place where you can go pretty quickly after you listen to the patient's story. So yeah, so your function is really only to create that space of permission so that the patient can be heard.
Thank you. I have a question also from Dr. Bock, who is asking if there is any evidence for higher osteoporosis and fracture risk in men with erectile dysfunction, because both conditions seem to share some common risk factors like low testosterone, reduced physical activity, depression, low vitamin D status. So do you have any data on that?
Mostly there are associations and not really hard numbers and hard evidence, but it pops up so many times. The doctor is right, that there really seems to be a connection.
Yeah, but I'm not sure if there's actual scientific proof that can say there's like a cause-effect relationship. So I wouldn't know if that's there.
There have been descriptions of also associations about a higher level of stress hormones, and higher level of interleukin-6, and a higher level of different stress hormones that seem to have an effect on the bones. And of course, reduced physical activity and low vitamin D states is very important.
Thank you. I have another question. Like, should we worry when a patient has problem in his or her sex life, or do we just need to accept it as a fact? That maybe the person is an old person, and that's a fact for a person in his advanced life.
I think we really should worry, because it has such a major impact on the quality of life. So the loneliness is really unbearable, and not addressing those problems of patients is really hurtful.
Yes, and I would like to add, we never stop being sexual beings. It doesn't matter how old we are, or what our health status is, or how sick or how healthy we are. So, I mean, you can even imagine if, let's say, you are so restricted that you have to stay in a bed all day. Then still, if your partner can give you a little bit of sensual touch on your face or on your arms or wherever you can accept it, that would already make a huge difference in comparison to not being touched, or only being touched in medical ways by medical personnel.
Now, I thank you. I have two questions and maybe some will come in your reference that are mentioned in your slides that we will share with our participants tomorrow. But two questions are coming from Dr. Witt and Dr. Bock. They are both asking if you have any advice or any knowledge about leaflet, other factual things that are available, or if there are any patient guides addressing this practical aspect of sexuality and physical intimacy in osteoporosis. So it seems that people are looking for references and for content to get to know more and to get knowledge.
There is some, but not so much, and we will send it afterwards what we have found. But I think we have to pioneer a bit on this subject, and we as healthcare professionals need to develop material like this, because it's very needed.
Yeah, so I think one thing that can help is to look into other disciplines, because in oncology, that part is much more advanced than in osteoporosis. So for oncology, as far as I know, there are more resources than on how to help and talk to oncology patients about sex. And I think that's also part of the cultural bias, right? Because when oncology patients can be much younger than osteoporosis patients, and there's much more emphasis on recovering sexuality after chemotherapy. But in osteoporosis patients, there seems to be an acceptance that it's just bad luck and they need to live with it. And so, that could help that you look into other disciplines. And you will find in the references, there's a study by McGrath et al. And that study has a huge reference list, because it's a very extensive literature study on scientific literature about talking to patients about sex. And if you simply go to that reference list, you will find a lot of literature, and you will see that much of it is from oncology. And also the document we just shared from the Royal Nursing College. If you just Google the title, you will find the PDF on ResearchGate. And then you can download that, and then you can simply assume, all right, if this is how we talk to elderly people, we can generalize that or transfer it to osteoporosis.
Many thanks, and we have reached the hour, so I think it's time to conclude. And so I would like to thank you all for your participation in this webinar, and we hope that you enjoyed this session. We will post the recording of this webinar on the IOF website, and you will receive your certificate of attendance and the link to the recording by email tomorrow afternoon. You will be prompted to fill in a survey immediately after this webinar. We would appreciate your input and comments. And if you have any questions, comments, please do not hesitate to send them at the address webinar@osteoporosis.foundation. I would like to thank you again, Ms. Offenberg and Dr. Asham, for this outstanding talk. I think it was really greatly appreciated by our audience. And I would like to wish a nice day or a nice evening to all our participants. Goodbye, and I hope you will be with us next month. Bye.
Thank you. Have a good day. Bye-bye. Bye.